Yeah, it's getting recorded, I think.
It is yet to get recorded. We are just, it is just showing setting up.
Yeah, it will take 10 seconds. Will be.
Yeah, it takes around 5 to 10 seconds, and
Yeah.
now it is being live streamed, and I'm very glad we also have the great Kiran Kulkoti sir with us. So I would just request him to unmute and
yeah, I'll start the introduction, please.
Yeah, we can start. Yeah.
Yeah, so I wish everyone a happy Krishna Janmashtami today. And already we have around 250 people logging in with us for this session, because we know it's very, very practical. So from Project Pelvis, it's always been our endeavor to make knowledge free of cost, which can be reached to every nook and corner of this world. And I know infertility has become a very kind of an epidemic now, where the numbers are increasing, and busy clinicians are unable to take time off from their busy obstetric practices in tier 2, tier 3 cities to go and learn about infertility. So these are our small efforts where we can at least help them out in a few ways, where we can help them implement some points what we have all learned. And especially Dr. Jai, who has huge numbers in infertility, and who has been very selfless in helping us learn all the things that he has probably learned over his practice. He is a fantastic endoscopic surgeon, but as well as a very, very good clinical infertility specialist, as well as an embryologist. So over to you, sir. I think, yeah, we have enough and more numbers now. So we will just start off with the lecture. So we'll keep it short. We'll keep it for 15 minutes. I know you're busy. You have to get back to OT. But at the same time, I mean, this is a one topic which is like, which has been requested by many, many, many members who have messaged me privately. And yeah, so you can go ahead.
Yeah, no, thank you so much, guys. I think there was a 10-minute apology. 10-minute delay from my end because of this problem, but I think it's okay. See, I'll just come straight to the topic, right? What is it that we are trying to achieve when we try to give trigger? Let's first just understand that. Okay. See, once the follicle matures, okay, so when we say that the follicle is mature enough, right? This follicle can reach its maturity governed by oocyte factors. So governed by how strong the oocyte is inside. All right. At an average size between 17 to 21 millimeters. This is the standard. Okay. It is actually the oocyte which governs all of this. Okay. So the oocyte which is present inside the cumulus, correct, that is going to govern the maturation triggers, which is going to happen over the endocrinological aspect inside that follicle. Correct. That is the reason why we get something called as a simple cyst. Okay. That is because inside that simple cyst, most of the times it was a apoptotic oocyte, which could not ensure that a rupture occurs or the final maturation occurs, and due to which that got converted, okay, by hyperestrogen secretions into a simple cyst. It's very, very simple, right? So that is the basis for giving your trigger. When you are trying to look at what happens in a natural course of menstrual cycle. In that situation, once the follicle reaches approximately between this size, between 18 to 21 millimeters, there is going to be a slight peak in FSH, which is followed by a peak in estrogen, which then triggers an LH surge. The exact mechanism with which this happens keep on changing with every new addition which comes. Okay, so don't get into the molecular biology of these things. Okay, there is then FSH peak, there is an estradiol peak, there is a small rise in progesterone, and then there is a huge LH surge. Okay, this LH surge is also a very powerful pulsatile surge. Okay, and this ultimately ensures that follicle and the follicular fluid inside it undergoes a series of chain reactions where it induces a rupture, where the cumulus oophorus complex gets released. Okay. Now, just because before the cumulus oophorus complex gets released, the oocyte from inside undergoes, it is arrested in a stage of meiosis and it undergoes the final maturation, which we then identify as a mature oocyte when we tell that, okay, this is a mature oocyte because it has a polar body which is present. All right. So the polar body is the completion of that meiosis, which is just prior to ovulation, which occurs. Okay. So this is the absolute basic of this entire thing. Okay. This God does in all the women, as long as these women have secreted monofollicular or, double follicular development through that menstrual cycle. This is what God does. Okay. And this is the same principle which we extrapolate when we want to do a natural cycle transfer, right? We don't interfere at all. We allow the follicle to grow. Only thing which we do in a natural cycle transfer is we monitor it. Okay. We don't even give trigger. We don't give trigger in a complete natural cycle transfers. No trigger is given. Understanding? Fine. So this is the logic. Okay. Now comes the question of what trigger, when, how. Okay. So ideally you should be giving LH, correct? Because it is the LH surge which causes maturation. But please understand, commercial production of LH is not very easy. Forget production. Isolation of LH is very, very difficult. If you ever go to a plant which is manufacturing HMG, you will understand LH isolate karte karte naak mein dam aa jata hai. Okay. As a result of which we use an LH surrogate, and this LH surrogate is HCG. That is because they almost share the same molecular structure. HCG is slightly heavier as compared to LH. Bas, isse zyada don't remember anything in the molecular aspect. Okay. They all of them go and act on the same receptor. But there is a problem. Okay. HCG commercially available, cheap, easy to produce. Any time pass person can come and start producing HCG. There is no problem. Okay. It is that easy to produce. Okay. The problem is LH surge gets cut off by God on its own. Okay. So LH surge gets cut off by God on its own. After it reaches a threshold, God will cut off the LH surge. Simple. Nature will cut it off. Okay. Which allows for a beautiful development of corpus luteum and which ensures that endometrial asynchrony doesn't occur. Understanding? The problem which we face when we give any form of trigger is because it is not LH, that means it is HCG. HCG sticks onto that receptor for a prolonged period of time. Because it sticks onto that receptor for a prolonged period of time, wo maturation to karega. It will cause maturation of that oocyte to occur because it is mimicking LH surge. Understanding? But because it stays there for a long period of time, iske wajah se all problems happen. Understanding? It can cause endometrial asynchrony. It can cause endometrium to go out of that phase with window of implantation. It can cause problems like OHSS because it has stuck there for a long period of time. So vascular channels stuck, remain there for a long period of time. Understanding? All these are our practical problems which we face. है ना? Then comes our decision making. कि भाई मैं कौन से situation में कौन सा trigger use करूँ? So simply to avoid OHSS, we came up with a concept that ठीक है, we will use GnRH agonist. What is GnRH agonist? We all know. It is going to act onto the GnRH receptor and promote it. So when it promotes it, there is that initial flare. FSH goes up, LH goes up. And this LH is enough to cause maturation of oocytes. Understanding? But remember one thing. GnRH agonist, when you give, after that initial surge, it causes a drastic cut. Because it causes a very drastic cut, the corpus luteum which is formed is a defective corpus luteum. And this corpus luteum undergoes premature luteolysis. Because it undergoes premature luteolysis, okay, because that happens to the corpus luteum, just a GnRH agonist trigger is not recommended when you want to have fresh cycles. And just in case you are a little dead shana person and you want to do a GnRH agonist trigger in a fresh cycle only, barabar, as a result of which you are told to do an HCG add back. Understanding? Very simple logic. There is no rocket science in this logic. I hope people have understood this much, because if you understand this much, Then I will draw the diagram. And once I draw the diagram and I explain it to you, then life will become very easy. You will understand which trigger to give when, what to avoid in which trigger, and what should you keep in mind while giving a particular trigger. Understanding very small flowcharts. Kyunki dhyan rakho, when we give trigger, we just have three options. Either we give HCG alone, or we give GnRH agonist alone, or we give a double trigger. That is combination of HCG plus GnRH agonist. Nobody gives recombinant LHS trigger in India. Okay. The cost of giving that much recombinant LH is more than cost of the IVF cycle. Okay. So nobody gives that superb logic. I will give pure physiological trigger in the form of recombinant LH. That is not given in India. That is not given anywhere in the world as well. Okay. So I will just, if Shilpa madam, this much is okay, then I will just start sharing the screen and draw the diagram for everyone.
Yes, please.
Yeah. Okay.
So here we want you to touch upon the trigger for just simple ovulation.
Everything. Yes.
Yeah,
I will just I will simplify it so much that hopefully, okay, if people just study this one flow chart, no, then for the entire life they will not require a repeat session on triggers. Okay. So I'll just share the whiteboard. Okay. The whiteboard is visible, right?
Yes.
Okay, fine. Fine. So see, we are basically planning to study trigger. Okay. And let me just draw everything as far as the trigger is concerned. So I will mark everything separately. So I will mark HCG trigger here. Okay. I will mark GnRH agonist trigger here. And I will mark double trigger. Okay. So dual, when I say dual trigger, it is simple. It is a combination of HCG plus GnRH agonist. Okay. Fine. Now remember one thing absolutely categorically. Whenever you are planning to do anything in fresh cycle, okay, HCG trigger is your trigger of choice, irrespective of the responder. Okay, this can be a normal responder, poor responder, great responder, very poor responder, whatever. If it is a fresh transfer which you are planning, then your HCG trigger should be the trigger of your choice. Okay, of course there are variations, but we are talking for a broad perspective. Okay, Shilpa madam, is it visible? Everything?
Yes.
Fine. If you are planning for FET only, okay, that means you have 100% told the patient कि तेरा कुछ भी हो जाए, I am going to be doing FET only. Then you have two options. Either you can use dual trigger or you can use GnRH agonist alone. Okay. So this is for FETs only. All right. Now you can have multiple indications of doing FETs. Irrespective of what you try, you can have hundreds of indications for doing all these things. But I just want to give you some important points. Please remember, because see, the normal physiology is such, no, that when you are trying to study the physiology for getting a good oocyte. Now, don't try and ask me what is a good oocyte. Okay, a good oocyte is any which ways somebody who has undergone good maturation and who has good structure from inside. Okay, so it is a metaphase 2 oocyte. For that to happen, you need FSH to peak. Along with that, you need estrogen to also peak. Along with that, you need LH to also surge. And along with that, you need that small progesterone also to rise and then progesterone to go up. Understanding? Ye charo cheez, when you can ensure, okay, if you can ensure that there is an FSH peak, okay, if you can ensure that there is an LH peak, and if you can ensure that simultaneously E2 estrogen also rises, in all this situation, no, one thing is for sure, you are going to get a good oocyte. Okay, so GnRH agonist fulfills this criteria for you. When you are trying to look at GnRH agonist, this particular gentleman fulfills this criteria. It causes an FSH rise and it causes an LH rise both. Okay. Now, because both of these things rise, it is ensuring that the first set. So when we are looking at the ovary, and let's assume you have a normoresponder for the time being. So let's say this normoresponder, has 12 good follicles. So let's say it has 6 on one side, 6 on the other side. Okay. In that, what will happen is out of this initial peak, this one, and this one will already receive its maturation. Okay. This HCG, which you are adding as a dual trigger with it, now because it has a prolonged action, okay, bhool se, मान के चलो, if GnRH agonist forgot to act on somebody, this prolonged action wala thing will come and act on this follicle and this follicle also. And your dual trigger will allow you to have excellent metaphase to oocytes in a very good quantity. All right. So that is something which you have to keep in mind. But remember, because you have given some form of GnRH agonist, these 4 follicles will begin their luteolysis very fast. Despite giving an HCG add back, they will begin their luteolysis. And because they undergo a luteolysis, this is good only for doing an FET. Okay. Do not try to conceptualize a concept by saying that I will give GnRH agonist trigger alone and not an HCG trigger. In fact, there is no higher risk of adding a HCG when you are doing an IVF cycle, as long as you are planning an FET only. Okay, but if you are very, very darpoke, then you can give just a GnRH agonist, and GnRH agonist should be your primary choice for an FET cycle. So when people often say that, but what about poor responders? Remember, in normoresponders, in hyper responders, as well as in poor responders, there is really no big difference. But yeah, only one thing, if the patient is a hyper responder, then a lot of people want to avoid an HCG add back. Okay. They want to avoid this HCG add back along with this. Okay. So just keep that in mind. Isse zyada, kindly do not think of this section for your practical purposes. Do not say I will do an IUI with GnRH agonist trigger unless there is a super special circumstance. Do not say I will do an IUI with a dual trigger unless there is a super special circumstance. Okay. Everybody else, fresh transfer, natural cycle intercourse, okay, IUI, whatever you are else you are doing, in all these things, your HCG trigger alone is more than enough. Okay. You can use natural cycle intercourse, you can use clomiphene, you can use letrozole, you can use HMG. Okay, whatever you want to use, as long as it is something which is related to natural cycle triggers. Okay, please remember HCG is your trigger of choice. Okay. Also remember, whenever you are doing any of these cycles, or whenever you are doing an IVF cycle where patient is not for double stimulation, okay, where patient is not for double stimulation, understanding, and if it is a poor responder, okay, in that poor responder as well, okay, in that poor responder which is not for double stimulation, then also your HCG is your trigger of choice, because it will allow for excellent maturation of oocytes due to its prolonged activity. It will take care of all those late latif oocytes and it will give you an excellent response. Okay. Another common thing which people 150 times everybody will ask the same question as far as this HCG trigger is concerned, that what type of trigger shall we give to our patient? I mean, what should be the dose that we should be giving to our patient? Should it be 5,000? Should it be 10,000? Should it be 2,000? Should it be 1,000? Should it be 100? Okay. Okay. So understand your LH peak, no? What is the peak value of LH at LH peak? Do you know? It is approximately 40, maybe 50. Okay. LH does not become 5,000. Correct? LH is approximately 40 to 50. Got it? How much HCG you are giving? Even if you are giving 2,000 international units, you're giving 2,000 international units. Let's say you are giving 5,000 international, 5,000 international units. Okay. In all of these situations, it is important for you to understand that you give what you want to give, yeah. You give 5,000, you give 10,000, doesn't really matter. There are some people who are going to say, I like to give only recombinant HCG in the form of Ovulation. Very good. That is equivalent to 6,500 international units of HCG. Okay. So kindly don't micromodulate it in that manner. Look, even if you give 10,000 international units or 10 lakh international units of HCG, once the receptors are completely occupied, no new receptors will come. So that particular HCG beyond its fulfilling capacity will get washed out from the body. Understanding? There is nothing called a circulating HCG which binds to somebody else. So don't worry about that. Okay. So if you ask me what I do in absolute standard clinical practice where I don't want confusions, is I tell the staff, aankh band karke 10,000 international units laga dalo. Okay. The staff should always give 10,000 international units. If you want, so they should not sit down and calculate. No, BMI 21.2, 5,000. BMI 21.3, 10,000. No, all these things, do not do it with your staff, please. Okay, because there will be one occasion where instead of 21, they will write it as 22, and then you will end up firing your staff for not doing anything. Better option, make it 10,000 for everybody. Okay, make it 10,000. Keep only 10,000 available in the hospital. We have 5,000 which is available only when we want to use low dose HCG, for treatments, and that is kept in a completely different compartment in the cold room. Okay, and this is something which is very practical, because when you have large numbers, these are the commonest mistakes no lecture can teach you. Okay, so this is one thing which you should remember about HCG triggers. Okay, one more thing I just wanted to add before I finish this entire trigger. Lot of people say that if an LH surge has occurred, and then when you give an HCG add back trigger, okay, it is going to be detrimental to the endometrium, which is absolutely correct. You should not do that at all. Okay, just in case you have a situation where you have given a trigger but follicle has not ruptured. Okay, today I gave a trigger at 19 millimeter, follicle did not rupture. Patient came back after 2 days and you wanted to document ovulation in the form of free fluid in the pouch of Douglas. That could not be documented. Correct? No? That does not mean you give one more 10,000. Okay, please remember that. The trick is ensure that your HCG's cold chain is very good. If the cold chain of your HCG is very good, no, it is not mandatory for a follicle on whom 10,000 has been given to have ruptured and then collapsed and formed a corpus luteum, and for you to see a free fluid in the pouch of Douglas. All these 4 points are not mandatory. If you have a patient with endometriosis where ovary is stuck, that free fluid will actually go into the descending colon peritoneal gutter, ascending colon peritoneal gutter in the right and the left respectively. You are not going to look at the free fluid in the hepatorenal pouch to ensure if ovulation has occurred in that particular patient. So don't really go by that particular logic. Okay. The commonest phone call we get is, मैंने 10,000 HCG दिया था संडे को, पेशेंट को मैंने बोला था रात को 10 बजे को ले ले, पेशेंट मंगलवार को सुबह को मेरे पास में आई, कुछ नहीं फूटा है. It's okay, yaar. It's really okay if the follicle is not ruptured. Follicle is not a husband that it will follow all instructions, yaar. The follicle will rupture at any time from 35 hours to 45 hours. In between that, ऐसा किधर भी नहीं लिखा है that it has to rupture at 36 hours. Nothing like that has been mentioned in any of the textbooks. Okay, so keep that in your mind and probably follow your protocols the way you are. One more thing which I wanted to tell before I finish, and this is the last point. Please start looking at the vascularity of the dominant follicles. Okay. Don't go into the depth and logic. PSV more than 13, PSV more than 20. Very good. Very good. It is good to look into it, but kindly start adding Dopplers to your lead follicles. When you start adding Dopplers to your lead follicles, where the PRF scale is kept at less than 0.3, and if you have a good vascularity at 3 walls of the follicle, all right, or if you have a good interfollicular vascularity, matlab between the 2 large follicles, if there is good vascularity going in, you don't really have to bother about rupture. Okay, वो rupture होएगा ही होएगा. Don't worry about it. Understanding it has to rupture as long as your HCG is good. Okay. Lot of times when people blame lack of ruptures, lot of time when people blame LUF, okay, in all these situations, the biggest problem is the brand which you have chosen for giving your HCG. Okay, kindly stick to one brand. If you trust a particular brand, kindly stick to that particular brand for a prolonged period of time, and you will start getting fantastic results. And with HCG, it is very important to maintain a good cold chain. Okay. As far as GnRH agonist is concerned, lot of people say that they like to use Lupride. Okay. Some people use 2 ml, some people use 3 ml. I have not used Lupride so much in my practice. I have always been using Decapeptyl, and I have used Decapeptyl since the past maybe 7-8 years in my practice, and I have not shifted the brand at all. Okay. So normally if I am giving GnRH agonist trigger alone, then I give 0.3 international 0.3 units of Decapeptyl. If I am giving a dual trigger, then I give 0.3 Decapeptyl plus 10,000 HCG. So I know that 0.2 units of Decapeptyl is also equally good, but we have standardized it irrespective of the weight of the patient, irrespective of the size of the patient, irrespective of the day, irrespective of the country, whatever it is, you give 0.3 international units of Decapeptyl. Okay. And that is some standardization which we have done. I know many of my friends, very good friends of mine, who are using 0.2 units and get excellent outcomes. So there is no problem in that. People who are satisfied with 0.2 can use 0.2 as well. Okay. One rare situation which I want to tell, and which is again the commonest phone call which we get. अरे मैंने patient को बोला था that you have to take dual trigger, 0.3 Decapeptyl and 10,000 HCG. Patient took only 0.3 Decapeptyl. Now what will happen? And now when can I give 10,000 units of HCG? Look, you can give this in the first 6 hours after the Decapeptyl trigger. I don't know if it is mentioned in any textbooks. I really don't know. I don't go through so many of papers and guidelines and all these things. But you can give it to approximately 6 hours, because usually people who are triggering in the night, by the time they remember and call your nurse, and by the time your nurse calls you up, no, 3-4 hours would have passed already. Okay. So the minute you realize it, and if it is within that 6-hour window, you can give an add back 10,000 HCG trigger. It will help your patient. It doesn't really have any detrimental, it really doesn't have any detrimental effect. And finally, before I stop, urinary HCG and recombinant HCG have the same outcomes. Okay. This has been proven in multiple records, multiple guidelines, and in multiple countries. There is nothing which states that if you use recombinant HCG, the oocyte quality is better. And there is nothing which states that when you use urinary HCG, there is going to be some impurity. And because there is going to be impurity, the oocyte quality is bad. Because there is impurity, you are giving 10,000 international units, guys. Okay. And when you are giving 10,000 international units, मान के चलो 150 units are impure. That impure unit will not go and stick to the receptor only. Why worry? Why worry about it? God will only make the pure international unit to go and stick to it. So don't get bothered about all those things. Okay. I hope this satisfies everyone as far as trigger is concerned. I wanted to keep it short and absolutely practical on what people should remember without going into molecular details. And I can probably maybe answer 1 or 2 questions if at all people have.
Okay, so there is a endometriosis patient having 1 endometrial cyst but 7 good dominant follicles. Should we?
What is the size of the cyst?
She has not mentioned, Dr. Kavita. Okay.
No. So if there is an endometriotic cyst which is more than 3.5 to 4 centimeters, for God's sake on earth, kindly do hell with the ESHRE guidelines, operate that patient, reduce that endometriosis, okay, and only then go ahead with the stimulation, okay, in these patients.
Okay. So do you ever repeat the trigger of ovulation after 72 hours? Okay, no. In IUI cycle after HCG trigger, no ovulation after 36 hours, the follicle becomes 25 mm.
You don't really probably do an IUI and then just leave it to God. See, sometimes what can also happen is the follicle has ruptured, but it has sealed back. Okay, ovulation has occurred, ovum has been released, okay, but the follicle has sealed back. Okay, once the follicle gets sealed back, you will probably not get a very good corpus luteum, because for a good corpus luteum to form, the follicle has to actually shrink and then it forms corpus luteum, right? So that can also happen. Do the IUI and leave some things to God in that particular cycle, and then take it forward from the next cycle.
Okay. Yeah, I think you have to get back. No? So we'll wind up. Any questions? We will take it in the WhatsApp group, but it was excellent. Thank you very much. Thank you for sparing your time. Thanks.
Yeah, I will just stop the Facebook live.